Evening, everyone. My name is Lindsay and I am the Client and Lab Services Manager here at Examen. And it is my pleasure to welcome you to the 6th webinar in our 2022 Male Fertility Series. As some of you know, we have these webinars on a monthly basis and we are joined by an expert in their field of fertility treatment or therapies. The event is free and open to everyone, and we have a wide range of participants joining. The views presented in these webinars are the views of our speakers and not necessarily of our company Examen. You're all very welcome to join us this evening, so please let me introduce you to our speakers. This month, we are delighted to have joining us Dr. James Hotaling. Dr. Hotaling is an Associate Professor of Urology and Director of Men's Health at the University of Utah. He has founded 3 companies related to men's health, one of which has an FDA-approved product on the market. He also holds multiple patents and has over 200 publications. He has expertise on the impacts of male infertility on somatic health, genetics of erectile dysfunction, and innovation in men's health and infertility. He is also an associate editor of Fertility and Sterility and will be the president of the Society for the Study of Male Reproduction in 2023. Our chair, Professor Sheena Lewis, is the founder and CEO of Examen. She is widely published and has been an office bearer of UK and European learner societies for the past 20 years. Before I hand over to Professor Lewis, I will just run through some housekeeping. We will start our webinar this evening with a welcome and introduction from Professor Sheena Lewis. Then at approximately 6:15 to 6:45, we will have our guest speaker presentation, followed by a Q&A session with our speaker and Professor Lewis from 6:45 to 7. Please do pose questions throughout the talks using the Q&A panel, not the chat function. You also have the opportunity to rate questions, and Professor Lewis will then chair the questions during the Q&A session. If you experience any technical issues, please use the chat function and we will do our best to help you. Attendees will be muted throughout and in videos enabled for our speakers only. All the events in the series are recorded and made available on the events page of examenlab.com following each session, so you can watch any events you may have missed. Please allow us up to 24 to 48 hours for the recording to be available. 1 CPD point will be awarded for attendees for the 1-hour event, and a certificate will be circulated a few days after tonight's webinar. At the end of the session, you will be invited to rate the event. Please do so, and we welcome your feedback on tonight's webinar, as well as suggestions for future sessions. So without further ado, I will now hand over to our chair, Professor Lewis, to start the session.
Good evening, everyone. We're absolutely delighted to know that you're with us. We can't see you, we can't hear you, but we're certainly hoping that you're going to give some questions so that we can have a nice lively debate once Jim has finished talking to us. And tonight we're talking about a really big issue, and that is about sperm selection. Because for a long time, as you know, in our company, we've been talking about diagnosing sperm health, looking at DNA fragmentation. But that's one thing, that tells you what the problem is. It doesn't tell you what the solution is. And over the last few years, a number of different companies and different techniques have been used to try and sort out the good from the bad. So that's what Jim is an expert talking about, and he's going to be talking to us about that later. Now, the purpose of these webinars is to raise the awareness of male infertility, because even though we've been talking about this for such a long time, there's still lots of people who think that fertility is a female problem and it's not really anything to do with the man. And we want to disabuse them of that and tell them that really it's a 50-50 problem. And so we should be giving 50% of our time and energy and research and efforts into solving male fertility problems as well as solving female ones. So we want to provide men with knowledge and to provide them with opportunities for advanced testing. And that's why we have the topic that we're talking about tonight. Our mission and our purpose are to demonstrate that couple care, looking after the man and the woman, can improve live birth rates. And of course, that's what every couple wants. We also want people to know that by optimizing sperm health, you can improve fertility outcomes. And of course, that's true in many different ways. Men can improve their sperm quality because they produce new sperm on a regular basis, unlike women who have all their eggs before they're born and their eggs just get older as they get older. And we have this crazy big objective that we would like to help 1 million men on a fertility journey. But over the years, we have done quite a lot of tests with sperm DNA damage, and we have looked at prescription drugs and infertility. We've looked at cannabinoids, cannabis, and the whole range that's within that family, and whether that's a biomarker of fertility. And I think it would probably be a pretty good one if anyone had the time and funding to look further at it. We've looked at pentoxifylline as a way of improving men's motility if their sperm don't swim very quickly. We've looked at the impact of diabetes on fertility. We've looked at vasectomy reversals and what happens when a man has a vasectomy and how his sperm are affected if he has that vasectomy reversed with a second or subsequent partner. Recently, we've been looking at men and miscarriage, which is a really exciting area. And you may know that we have published in the Lancet from the HAB Select study, and we published another paper earlier this year looking at the relationship between sperm DNA, miscarriage, and also the benefits of the pixie dish to prevent miscarriages occurring. And the final thing that I'm particularly interested in is DNA damage and unexplained infertility. These are the couples. Doesn't seem to be anything wrong if you use traditional tests to check it. And yet, if you look at these guys, 40% of the men have DNA damage, and that is definitely a contributory factor to their infertility. At the moment, we're doing research both into men and into their sperm. We're looking at the effects of varicocele and the impact that that has on ART outcomes. And we're looking at the effects of repairing those varicocele and how that improves outcomes. We're looking at infection, and we're looking at men's microbiomes. And then, of course, in terms of their sperm, as I've already mentioned, we want to know more about unexplained infertility, about sperm sorting techniques, and that's where Jim comes in tonight. And also looking at sperm DNA as an indicator of overall health in men. And that's a wide-ranging possibility, because that's not just looking at men who have fertility problems, but it's looking at men's DNA quality and saying that could be a biomarker of something that's going to happen to your health in the future. Now, understanding our test, it's quite a simple test. And here on the right-hand side, you can see that you have a traffic light of green, yellow, and red. And what we are able to tell you from our test is how many good sperm you have in the green area, how many average ones you have in the amber area, how many bad ones you have in the red area, and then an overall average COMET score to tell you what your overall rating is. And we know that from these measures, compared to those of fertile men or compared to couples who've had successful live births by assisted conception, we can tell you that high DNA damage can lead to an increased risk of infertility, lower success rates with IVF, and increased risk of miscarriage. So the threshold of DNA damage is a really important one for many different illnesses. We're absolutely delighted that over the last couple of years, not only what we've been saying, but people have taken notice of it, and now DNA damage is being included as a measure in international fertility guidelines. That's true in Europe, in the European Association of Urology, in their guidelines on sexual and reproductive health. It's true in ESHRE, which is the European Society for Human Reproduction and Embryology. And here, everyone is saying assisting sperm DNA fragmentation is something that we ought to be looking at, because the evidence is becoming greater and greater. And across the pond, where our speaker tonight is from, the American Urology Association and ASRM are also saying the male partner should be evaluated by a male reproductive expert, yes to that, and also consideration should be given to the evaluation of his sperm DNA fragmentation. And then finally, just to point out that the WHO laboratory manual, that's for the whole world, the one that came out recently in 2021 showed that for there was a really important place for sperm DNA fragmentation in an extended examination, not just looking at sperm counts, sperm motility, sperm morphology, but also looking at DNA to get a picture of what the problems were. So tonight we have the great pleasure of having James Hotaling with us, and he is an amazing guy. I first met him, I think, Jim can correct me if I'm wrong, in 2014 in Honolulu at an ASRM meeting. and the rain was coming down, and it was really serious weather. But the thing about it was that there's nothing else to do in Honolulu because it was such bad weather. So everybody came to the lectures, and a lot of friendships and relationships were built up on that occasion. James is a fellowship trained urologist. He's been specializing in male infertility through his training and since his training. He's graduated from top class universities, Duke University and the University of Washington. He is trained under Craig Nigerberger, who's a very, very famous guy in the whole area of microsurgery for testicular sperm. Jim is also a fellow of the European College of Sexual Medicine, and he's been funded by NIH. And when you get funded by NHS, it shows you're pretty top notch. So what he's going to do tonight, he's going to talk to us about sperm selection. I have had a look at his slides already. I know we're in for a very exciting talk. I hope that you're going to ask questions because there are lots of things that I want to know the answers to as well. So now I'm going to hand over to Jim and he can tell us a little from his expertise. Thank you very much.
Well, thanks for that really nice introduction. I do remember the rain. It was impressive. All right, let's see. Let me pull this up here. View, presenter view. Okay, let's see. Oops, it went wrong. Let me just get to the beginning here. Sorry about that. Okay, can everyone see that now? Mm-hmm. Yeah, so I'm really excited to talk to everyone today. This is I think a really important topic. And I'm going to try to explain like why this is important and then what we might do about it. These are my disclosures. One is directly related to this. I did have a sperm sorting company that was sold to a company called Co-Diagnostics. So I'm out of that, but do a number of commercial things. So one of the big questions, this is obviously a famous couple, is that, it's well known that as men get older, they're at risk for higher DNA fragmentation, more mutations, higher rates of autism and schizophrenia. One question is kind of what drives all that? And also, is there a subset of men that have an even higher risk of that? So to think about that, you have to understand a little bit about a germline mutation. And this is kind of when we think about what the future really is, what's kind of the holy grail of sperm sorting. It would be to fix this issue. So a germline mutation is something that arises in a maternal or paternal gamete, and it's new, and it can be transmitted to offspring, and it can have, deleterious effects and be involved in disease processes. And the big problem we have in fertility right now is we have no way to select sperm that don't have these mutations. We know that, 1 in 15 guys have these mutations, but we don't really know how to pick the optimal sperm fully. I'm going to kind of cover what we can do right now. So what can we do to pick an optimal sperm, and what do we need to understand to really cover this topic? Well, first of all, we have to understand a little bit about microfluidics, and I'll explain why that's so important in just a second. We need to talk about what it can do, what it can't do, and then we really need to outline what the optimal test might look like. So, the first thing to keep in mind is the goal is not to replicate the work of this company. I don't know how many folks over there are familiar with Theranos. I assume some probably are. There have been a bunch of movies done on it. It raised hundreds and hundreds of millions of dollars and was a complete fraud. It was all a sham. So whatever's done, I think, for this by commercial companies the science needs to be there. And we really need to leverage what's there in the science to optimize care for patients. One of the other big limitations in our field, and I don't have to tell, Dr. Lewis this, but is the semen analysis. It's not a great test. It's not perfect. These are all editorials I've written, kind of ripping it apart over the years. Total molar sperm count's probably the best metric from a standard semen analyses that we have, but it's far from perfect. So why am I going to talk to you about microfluidics? Well, it's really for one reason. It's the only modality that can deliver functional diagnostic sperm testing with an emphasis on functional. If you look at the number of publications in microfluidics, they've gone up significantly over the years. And microfluidics holds a lot of promise for our field because it has the ability to sort sperm and it's still usable at the end. There's lots of ways to figure out which sperm is great. In fact, you can even sequence a single sperm, but you kill it in the process. So, what's really the definition of functional? It's really having a utilitarian purpose and capable of serving the purpose for which it was designed. Well, functional sperm is really the ability to fertilize an egg and result in a healthy baby. And the challenge we have is that you start with a whole population of sperm, but ultimately you only care about a subset, and sometimes even only one. The sperm will fertilize the egg and, hopefully make a baby. So back to this thing, when you think about, one sperm versus a population of sperm. So you have all these different spermatogonial stem cells, and most guys are making about 1,000 sperm a second. It's the highest throughput process in the human body, and it just generates a huge number of sperm. And as men get older, some of these spermatogonial stem cells accumulate mutations and don't make sperm that is as fit as other sperm. So what you really want to do is you want to pick kind of the Michael Phelps of sperm, if you will, famous swimmer, but you want the one that not only swims well, but also is the most functional. So here, if you look at this, there's kind of one sperm that's swimming way faster than the other one. So what if you could select that? And what if that one was more optimal for reproduction? And that actually, I want to take a second on this slide and explain something, is that just because a sperm is faster doesn't necessarily mean it's the optimal sperm for reproduction. There's lots of guys who have sperm that swim really well. They have a lot of sperm and they still can't get somebody pregnant, often due to, potentially issues with DNA fragmentation, the epigenetic profile, de novo mutation rate, a whole number of things. So one fundamental question is, do we care about population effects if for IUI, IVF, and ICSI, we're just going to rely on a subset? Wouldn't we be more interested in identifying and using the best sperm? Most of these commercially available tests, including the work that I've done, really deliver a population of sperm that's hopefully more healthy than the others, but it's still a population, and it can have heterogeneity within it. So back to this thing about microfluidics. This is a microfluidic sperm sorting chip. You can see the little spiral channels. These things are not expensive to make. They can be made for a couple dollars once the molding is done, and the sperm get put in at one inlet here and come out at the other inlet. There we go. Messed myself up moving stuff over. So when we think about this, you standardly, you have a microscope, you look at sperm. When you use a lot of these tests, DNA fragmentation, test for reactive oxygen species, you can't use that same sperm for like assisted reproductive techniques. And the fundamental issue is that to know what the DNA fragmentation is of an individual sperm, you have to kill it. There's no real way to do that and use it, at least right now. So microfluidics really lets us do that. It lets us sport sperm and then try to find the optimal one, and then hopefully be able to make a baby. So back to this issue of a population of sperm versus one sperm. All of the available procedures, other than maybe ICSI, evaluate a population of sperm. Ironically, you could argue that ICSI is the best test ever of reproductive potential of an individual sperm, because you inject that sperm and you either get a healthy child or you don't. We are interested in one sperm for ICSI and a limited subset for IUI and also for IVF. Microfluidics lets us do that, and that's why I think it's so cool. This is, as most things, this is not a new idea. Gary Smith, who, some of you may or may not be, familiar with. I don't know if Shana saw any of his work when he was at University of Michigan, but he was really was an early pioneer in microfluidics for assisted reproductive technologies. He had multiple articles in the early 2000s, but it never really took off because the technology just couldn't keep up with what it needed to do. It wasn't fully there, and it wasn't ready to have a big clinical impact. Well, that has now changed. The goal of what we're trying to do is really sperm sorting on a chip. We take a sample from an individual user, we put it into a unit, The unit would have a disposable microfluidic chip, and it would remove all the stuff you don't want and keep the sperm. You could distribute it in cryo tips if you were going to freeze it or get it ready for insemination or IVF, ICSI, whatever you're going to do. So how does microfluidics work? I think if you take away only a couple things from this talk, it's that I hope you have a basic sense for how microfluidics works, and it's not just this big black box. I'll talk a little bit about sort of AI and machine learning at the end, and that is also a big black box. We don't quite have the time to get into the details of that. But microfluidics is manipulation of cells through channels with dimensions on the orders of microns. So you're pushing things through really small channels, essentially. It allows for really precise control of a cell's environment, and it makes it easy to manipulate that environment because the fluids are at very small volume. It's amazing for processing samples with low cell concentration and or small sample volumes. And there's microfluidic chips that can identify, one cell out of tens to millions of cells. It's pretty incredible. So how does this work? Well, really there's, when it's going through these channels, there's lift flow and there's Dean flow. Lift flow pushes the particles out, kind of centripetal force, and Dean flow pushes the particles in through some kind of recirculation. You get a dynamic balance between these two cells, and then they sort by size and shape. And this is an example of one of these chips where a heterogeneous population, this is from one of our papers, of cells goes in, and then they get sorted. The sperm goes one direction and the white blood cells go another because of the balance of these forces, and they get sorted by their shape. So another way to think about this is kind of the sperm Olympics. That's how I describe this to people, different mechanisms. You have something called parallel laminar flow, where there's flow going across a channel and some of the sperm swim out of the channel and some stay in it. There's chemotaxis, where the sperm swim towards some kind of chemical attractant. There's an obstacle course in subpanel C there, or there's a microdiffuser where you take a population going in and they go different directions. So these are all different ways to sort sperm. One of the challenges that for here, all of these rely on sperm motility. And what's problematic with that is if you're using sperm with either really low motility or testicular sperm, this route isn't really going to work. So spermatogenesis, as I mentioned before, is really high throughput. Just huge numbers of sperm are being produced all the time. And these, stem cells, we want to find the sperm that's going at, ludicrous speed, faster than the others, and to be, more reproductively fit. Now, the question of whether speed equates to fitness is kind of a separate issue, and we don't totally know the answer to that. However, most commercially available microfluidic sperm sorting chips that are on the market, such as the Zymod chip, do sort effectively for motility, and more motile sperm have a lower DNA fragmentation. But really what they're doing, they are not selecting specifically for DNA fragmentation, they're selecting for motile sperm, which happen to have lower DNA fragmentation. So these are all different configurations of these microfluidic channels. We've gravitated towards the spiral channels because they're easy to make and it's easy to manipulate. You can change the width of the channels or the flow of things through the channels, and you get different results. So what can these channels do? Well, this is one that can sort sperm from blood cells, from cryptosporidium, from some small beads. And what you can see with these different colors is they're all going different places in the channel. So that's kind of how they sort. They're all moving to different places. The key, though, is that all these designs leverage particle separation through the inertia of sperm moving through a channel and just the balance of two forces. And based on the shape and sort of their speed, that's how they sort out. It's a very high resolution technique. You can even sort, chromosomes with certain devices. So what are the platforms for motile sperm selection? Well, here's one of them. It relies on sperm motility. So the sperm, go in here, they go into the microfluidic chip and they come out at a different place. This is another one where the sperm effectively are swimming towards the middle. Just an example of a collection chamber and the inlet there. What are some things that are on the market? Well, here's just one. This is the Koch Biotech Fertile chip. This sort of shows the strengths and weaknesses of some of the data. They looked at 265 patients. They used a density gradient to process sperm or one of these microfluidic chips, and they looked at insemination outcomes. And if you look at their data, you're like, oh, well, maybe pretty promising. Shows some effect. The p-value is kind of where we like to see it for ongoing pregnancy. But if you look at some of the confidence intervals here in the adjusted analysis, which is what people ultimately care about, it's successful either 12% of the time or 11% of the time or 1100% of the time. So it's like, which one of these would you actually use? Would you tell a patient to use a device like this? And that's kind of the problem with some of these. So moving on to morphology-based sperm selection. So this is another way to sort sperm. So again, the key thing is that these commercially available chips are sorting sperm based on motility. Our devices that we're working on are sorting sperm based on shape, kind of what they look like. So for example, a mixture of sperm and white blood cells go in, a syringe pump pushes fluid through this pump, and it comes out in two separate populations. And then, here's the spiral channel device. If you look at the features, of this, they're all customizable with height, radius, length, and the operating flow rate. And you have to tweak these to get kind of the results that you want from these chips. So when we look at the sperm recovery that we're getting from this, it's quite good. It's a higher recovery than insemination. It's faster processing. It can do 5 milliliters in 20 minutes, and it can be automated. It also has reduced reagent consumption. So these are all major pluses. When you look at what it can do in terms of cell recovery, it can retain 80% of all sperm and 87% of motile sperm and get rid of, we were looking at white and red blood cells, but get rid of a lot of white and red blood cells, which, as anyone who's worked in an embryology lab will tell you, one of the hard parts of processing testicular tissue to obtain sperm from a microtesty in particular is getting rid of all the other stuff that you don't want to be there, the white blood cells and the red blood cells. So we thought it had promise for that. When you started applying this to microtesty samples or samples from men with non-obstructive azoospermia, so essentially no sperm in their ejaculate, you put this in and you have an enrichment module, and then eventually you get more isolated sperm coming out. And we did a study and we found that it accelerated the sperm search tenfold, and that it also could improve the sperm search success rate. So when you look at the ratio between test and control results, you find sperm much more quickly if you look at how long it takes you to find it. This is the same tech, actually two different techs looking at things, either looking at the raw sample that came out from testicular tissue or looking at it that is processed through the device. And the device essentially cleans up, gets rid of all the stuff you don't want to see, and makes this a lot faster. So, this was, more work that we've done in the same area. This is, again, just showing the focusing. So how do these work? When you put these biopsy samples in, you're recovering 96% of the sperm, and you're getting rid of 87% of the non-sperm cells that you don't want. So you go from seeing, trying to find the needle in a haystack to trying to find the needle in 30 pieces of hay effectively, which gets a lot easier. So moving on from microfluidics, I'd like to talk a little bit, with my remaining time about imaging, non-invasive imaging of sperm, and then also talk about machine learning and artificial intelligence techniques that can be used to improve things. So if you look at, Raman spectroscopy, which is essentially a form of infrared spectroscopy where you shine a light at something and a CCD camera chip tells you what's resonating effectively. These units aren't that expensive. One costs about $30,000. At least it did in 2015. It's probably less expensive now. Well, actually, maybe more expensive now with inflation and everything else. But it's a cool technology, and people have used this previously. This paper is actually from 2009. There's several other papers to image sperm, but they've used fixed sperm. Essentially, they've used sperm on like a histology slide. because fixing moving or imaging moving sperm is harder. This is actually us imaging a moving sperm. And what we found, we started playing around with this, is that the Raman spectroscopy beam actually picks up the sperm. So it actually will, if you focus it on the sperm, the sort of electrostatic, charges. To be honest with you, I don't fully understand how it works, but I can tell you, talking to our physics people and our chemists, that it effectively just holds it there in place, but it makes it easy to image it. So this is looking at the head of the sperm and getting a heat map for what that looks like. We then built a custom chip here, and this is a video. It's very hard to see, but if you look at kind of the neck right here, you can see a sperm kind of come in there, appear there, and then disappear there. So there wasn't a sperm there before. So if you look right here, let me see if I can get it to where what's other. So you don't see a sperm, and then there's a sperm there, and then we can actually shuttle it one direction or another based on pressure. But this has a lot of potential, because you think about it, you could pause individual sperm and then look at it. And then decide what to do with it, keep the good sperm. Which, brings us to kind of our next point, looking at big data and, artificial intelligence. This was a famous chess match between IBM's, supercomputer, and I think it was Kasparov. It was the top chess player in the world. But people throw around, big data, artificial intelligence, machine learning all the time. But, we have to pause for a second and think about, like, A, what that is, and B, how can it be applied in an effective manner? And my thought was always, well, if you could image these sperm non-invasively one at a time, you could shuttle the ones who have, optimal characteristics one way and get rid of the ones that don't. And machine learning is a very appealing way to do that, because it can take advantage of massive amounts of data. So when you look at sort of big data and artificial intelligence, it's kind of, at least in the clinical world, like the buzzword that gets thrown around all the time, and sort of take bad clinical problem X, throw it into a big black box with machine learning and get amazing answers. We're now kind of finding out that it may not be as good as we thought it was, but I think it still has potential. You look at all these different companies, in the US and Europe that have raised crazy amounts of money at, billion-dollar valuations. I think those valuations are a little less lately, but it's still something that money is just pouring into. This is a company that promises to save hospitals money by processing their data. This is a quote from a famous venture capitalist: "Software will eat the world." And just meaning that software is going to be able to solve a lot of these really big problems. But the reality is that understanding impact and the monetization of big data is essential to practicing medicine in, 2021, 2022. This is, and fertility is no different. And male infertility is an area that's probably, 15 years behind where female infertility is, and is kind of a little bit of an orphan disease in the fertility world, and that 85 or 90% of the focus is on the female side. So when you look at big data, you kind of got to think about how it works. Really, what it is just really complex agnostic math or linear algebra. It's putting a ton of data in and having a computer find what's similar and try to derive equations to predict what's going on. And typically when you do that, you have a test set and a training set, but there's a number of components to it. There's sort of supervised learning and unsupervised learning. And fundamentally, the differences there are, to bring it back to the fertility space, for supervised learning, we give some a priori inputs and say, this is important, that's important, this is not important, and then see what the computer comes up with. Unsupervised learning, we just throw everything in and see what the computer comes up with. And one of the problems with that is that if the data going in isn't good, then the data coming out is not good. But essentially, this is just a network where you feed data in, you have an input layer, you have some other hidden layers computationally, and then you get an output, right? And in the US, there's FDA AI approvals. As far as I know, there's nothing that's FDA approved to use AI to sort sperm, but I think it's coming for sure. And I know there's definitely companies working on this. So when you look at kind of the whole range of artificial intelligence, it spans, this is from a big paper in, I think, like by Eric Topol in like Science or a very high profile journal. But one of the things they call out right here is embryo selection. What they don't call out before that is gamete selection. But I think all that is potentially coming. This can be applied to a huge number of different areas. The key here is that the input can be sequencing data, whole genome data, electronic medical record data, pathology, but the quality of the data coming out is determined by the quality of the data going in. So taking it back to this concept, now that we've learned a little bit about machine learning, we talk about machine learning in digital microscopy, and machine learning algorithms can incorporate a number of different things. This was a fertility and sterility paper that came out recently, looked at normalized spermic samples from 76 men undergoing IVF that were capacitated in vitro. It used flow cytometry to measure the pH and used computer-aided sperm analysis to measure hyperactivated motility. It put standard parameters in, and it predicted IVF success with an area under the curve of 0.81, which is not bad. It's really pretty reasonable. So where I'm hoping the field goes is sort of putting this together with what we use in the OR. We have these new 4K exoscopes. So basically, if you notice the microscopes there, we're operating, but everything's on the screen and we're wearing 3D glasses. So essentially, the output is all digital, like it's pixels. And the question becomes, why couldn't this be used to sort, to identify the optimal regions, doing a microtesticular or microdissection testicular sperm extraction? Like, why isn't that something that we can do? It probably potentially is in the future. So this is just the microscope. These scopes are very expensive right now, but the price is coming down. So I think there's a huge number of opportunities for machine learning. These are just some other papers. It's not quite ready for prime time, but I think to really hit this out of the park, you'd need to combine microfluidic sperm sorting, maybe at first pass to get rid of the sperm that you really don't want, and then start imaging individual sperm and using one of these machine algorithms to extract data from that. This is where I hope everything's going to go. I think we'll hopefully get there one way or another, but it's got big potential for the field, especially because the male side is farther behind the female side. So in conclusion, if you've taken one thing away from this talk, hopefully it's that microfluidics is super interesting and you now have an idea of what it actually is, and that it could really improve assisted reproduction. Morphology-based sperm selection in these spiral channels is a pretty elegant solution for functional sperm testing. And the fusion of real-time surgical digital microscope feeds and IVF lab scope images with artificial intelligence has significant potential for the field. So just a few acknowledgements here. If it'll go over, my computer's not. There we go. There we go. And then I will stop sharing my screen and I can take questions.
Thank you, Jim. That was really, really interesting. Yeah, I mean, it's just unbelievable what's happening. So having had a dearth of anything, and as we were talking about earlier, there's not even an antioxidant on the market that's got FDA approval. Now we're talking about umpteen really, really exciting approaches that we might be able to choose the best sperm. So I have a question for you. I know this is all fairly early research and it's a bit blue sky at the moment. Is there anything that you could think of that we could actually bring into the clinical laboratory at the moment, which would be better than what we've got now?
Yeah, I mean, I think probably hopefully we'll commercially have one of these microfluidic sperm sorting chips, on the market for testicular tissue. I think those are, definitely better. I think Raman spectroscopy is something that certainly, could be used. the question that has to be answered there is, does imaging the sperm like increase the DNA fragmentation? We don't think so, but it's certainly possible, shining this, really intense beam on them. Granted, it's for a short period of time. I think the other thing that can be brought into the laboratory and will be, it's not quite there yet, but soon is some of these machine learning data, machine learning algorithms, even an algorithm just picking the optimal sperm for ICSI. That's pretty low hanging fruit. And there are algorithms that can track, like under a microscope, obviously CASA, but there's other algorithms that are trying to do that. And I think it's just, some of these machine learning algorithms, some of those papers have like websites where you can, input the things and get an output for what success rate would be.
It's just, I think there's a huge amount of marketing being done at the moment for these. But when I look at the papers, the N number is usually under 100. Now, that's not true of the paper that you were talking about earlier, but the majority of them are. And I just wonder that, if it would be wise to throw away our density centrifugation and bring these in for convenience. There's absolutely no doubt they're more convenient in the lab. So I can understand why people will do it, but if we're wanting to get incremental improvements, I wonder if we're there yet.
I don't know that we fully are. I mean, when I look at all the data, I think I'm sort of hard pressed, to say, oh, you have to use this or you have to use that. The data is kind of all over the place. I mean, even with some of these chips that have good data there aren't like a lot of really big trials, looking at this. You worry about selection bias. But I think that point aside, even if they're equivalent, if they're faster, they're easier, they reduce technician time. And they also, a lot of them, if they're self-contained, can reduce the chance of reduce chain of custody issues, and issues. That's a huge part of it, of taking the human component, out of it. And it's easy to put like RFID chips in some of these, do you know what I mean, that link everything together.
Mm-hmm. Yeah, sure. And I suppose the other question is, do we have the data that shows that there's an actual impact on live birth rates? I mean, that's always what I come back to. It's fine talking about all the other parameters, but does it actually give more?
Yeah, that's the problem, right? And it's why I pulled up that one paper, and in the unadjusted analysis, they saw no effect, but in the adjusted analysis, they saw an effect with an odds ratio of 1.12 to 10.89. And to me, that's a big red flag. And, when you do clinical trials, you should have a primary endpoint, because, in the words of one of my statistics professors, you can keep doing statistics so you get the answer that you want. It doesn't mean it's correct. But that's the problem. And I don't know that I think if there was that data and it existed, every clinic in the country would shift to using this overnight if that data is clear.
Yeah. Well, we've got a couple of questions from the audience. One of them is, really lovely talk. Totally agree. Do you know how many live births have been reported using microfluidic stages?
That's a great question. Meaning, I assume what the question is how many live births have been reported after, after using one of these microfluidic sorting chips? Yeah. I have no idea, but I think it would.
1,000? Is it 5,000? Is it 100?
I would guess it's 5,000 to 10,000. I mean, a lot of those chips are, fairly commonly used. I mean, I think if you were to back calculate that, you could look at, Zymod, I think, is the one that's probably the most commonly used, at least in the US. You could look at what their sales were, and assume that, 35%, do you know what I mean, of those IVF cycles resulted in success.
Yeah. Okay. Here's another question. So if you have high sperm DNA damage, can you use testicular sperm? That's the first question. And then the second question is, what is your opinion of PIXI?
Yeah. So, yes, you definitely can. And that's actually typically what we offer. For the reason that I think the data there is a little bit better. I also think that there may be something else in testicular sperm, whether it's epigenetic changes that actually are giving you the advantage. So we often will use testicular sperm. I think where it gets tricky is like where you're using testicular sperm on every single patient before they've tried IVF even once. And some clinics do that. I don't do that. I will say if they failed IVF or if there's other like mitigating factors. DNA fragmentation, I think, can be an enormously helpful test when like nothing makes sense. In particular, like the guy has a total motor count of 100 million, the wife is 28, no female issues, and they just can't get pregnant. That if the DNA fragmentation is sky high and there's nothing else modifiable, you could consider that. In terms of Pixie, I definitely think it has potential. I didn't have time to get into it in this talk, but one of the other things that's tricky about our field is if you look at the R squared or the correlation coefficient, at least in Utah, between the age of couples, it's like 0.89, which generally means that like, generally speaking, older dads, tend to be married to like, or trying to have kids with women who are going to be older moms.
Yeah.
And a lot of these DNA fragmentation things don't fix a lot of older eggs have a harder time correcting some of these sperm issues. So I think there is potential there, but I think again, you need, really big trials, big, well done trials. And it's really hard to accrue patients for these trials, because if they get any sense that one thing is going to be better than the other, then they go with the thing they think is going to be better because it's so emotionally charged. So the other one was randomized controlled trials going on with microfluidic stages. That is a great question. That's the problem. I am not aware of like a single one. And it's because of, at least in the US, it's largely because how all this is regulated. Like if it was going, fully through the FDA, if it was, viewed as a drug or something, it would require a randomized controlled trial, or at least a non-inferiority trial before it would ever get out into the market. In the US, most of this stuff is, CLIA regulated or regulated, as a high complexity, like laboratory product. So the bar is lower and these companies have no financial incentive to do that trial because it could kill their business model. The most likely shot for that trial is probably if it's funded by like the European Science Foundation or the NIH or, somebody doing a big multi-center trial to just put this to rest one way or another, but that's going to be an expensive trial.
Can I ask you one final question?
Yeah.
I know you were talking about being able to choose sperm through microfluidics dependent on motility, which is an obvious one, even on morphology with other aspects. Neither of those are particularly good. For example, even Nixie, they're very little relevance. But the idea that you were saying that you could actually identify chromosomes. Now we know, for example, that chromosome 15 it's one of the ones with lots of DNA damage, and it correlates very closely to the psychiatric disorders. And John Aitken has said this over and over again. So is there any way that you can isolate chromosomes and have a look at them?
Yeah, that's the tricky part. You can, but as of right now, the sperm is not intact. Do you know what I mean? And part of the other thing you get with sperm is because the DNA is so compacted, to really look at stuff, you have to undo all that compaction. I think there will be, though, like ways to do that. I mean, there are so many advances in kind of, non-invasive, imaging. When I first started playing around with Ramon, that's exactly what I wanted to do. Even just basic like aneuploidy, right? Just saying like, is one, greater than the other? There have been companies like, Microsort was one that was sorting sperm for gender selection. They eventually got shut down. But that was effectively like a weight thing. Well, they got shut down in the US. I think they can still do it in other countries, but yeah, that's kind of where the promise is. And I think it's going to take like a technical leap to be able to do that and leave the cell still alive.
Yes, that's the huge problem. Now, what we would say is, because the DNA testing is so good and so reproducible, that if we tell you, you've got so much DNA damage this month, then the sperm that you're going to be using in ART next month, it's going to be very similar to the ones that are tested. So that's what we would argue on that. It's not like a semen analysis where it goes up and down every day.
Yeah, I totally agree with you. I think the challenge is like, what do you do about it? And lifestyle change is hard, and and like an analogy is like, in the US, like, they've had bariatric surgery for quite a while. The US has quite an obesity problem. Fortunately, Utah is one of the fitter states in the US, so less so, but they've had bariatric surgery for a while, and now there's like some pills that can cause people to lose 20% of their excess weight, and they're like very well tolerated. So people are like, well, I don't care. Do you know what I mean? Like, I'm not going to exercise and do all this other stuff. I'll try the pill, and that doesn't work, I'll do, bariatric surgery. But if you could come up with something, to your point, Shana, where, DNA fragmentation is reproducible, and you do have this subgroup of men with very high DNA fragmentation, and that's driving their issues. So if you could identify those men, which we check that box, that can be done now, but then to sort their sperm, I mean, that has a lot of potential for the field.
Yeah, absolutely. Well, that sounds like a really good note to end on, Jim.
Okay. Well, thank you all for your time, and I hope you guys all have a great night.
Well, thank you very much. It's been absolutely fantastic talking to you. I know our audience, we've got a few regulars, and they come back every time, and much appreciated to have your time. Lindsay, do you have anything further to say before we go? No, that's it. Okay, we'll see you all next month.